So now we talk about pulmonic stenosis. And in this pulmonic stenosis, as compared to aortic stenosis, believe my word, this is the simplest thing which we ever come in practice, encounter in our practice. But it's useful at the same time. So as we talked earlier, we have pulmonic stenosis per se, subpulmonic stenosis, suprapulmonic stenosis. We talked about supravalvular, subvalvular aortic stenosis. Here we talk of subpulmonic stenosis and suprapulmonic stenosis. Now look at this picture very carefully. Here is the leaflet, and all of these windows are in parasternal short axis view at aorta. If I look at this picture, this is tricuspid valve, this is inflow, this is outflow, this is proximal, and this is distal. This is pulmonic valve, and there's a pulmonic artery over here, which subsequently bifurcates to right and left. And if you look at this valve, looks to be thickened, but most important point is concentrate over here. As if some obstruction is seen over here. And how to prove this obstruction? This is a three-dimensional picture of the same thing. Look, this is pulmonic valve, and here is this so-called fibrous band in the subpulmonic area. And if you switch on our colors, at this particular point, the velocity is normal, but if I put my sample volume into this area, my velocity becomes mind-boggling. So aliasing starts happening in this area. Right. And this is how we take a sample volume from aortic valve to subpulmonic and suprapulmonic areas. And only the pulse wave will tell you whether this has got a value or no value. Now, another example. Look, this area is absolutely clean. Valve is over here, it's leaking. But you find a turbulence not at the valve, turbulence at the distal to the valve. This is known as suprapulmonic stenosis. Now, this is much better and clearer observation. This is a valve, here is a band. And you look at the blood is flowing from this window. I deliberately kept these two images together. This is a tunnel, this is an obstruction, some fibrous band from which the blood is flowing. If I'll keep my pulse wave over here, the velocity will come out to be normal. If I'll keep my pulse wave over here, aliasing will happen. So what I'll do, I'll switch over to continuous wave Doppler to look at the gradients across this suprapulmonic stenosis. And this is a continuous wave Doppler with a gradient of almost 4 meters per second. So as it was an aortic stenosis, so is in pulmonic stenosis. You have to find out where the gradients are. And this is a typical pulmonic stenosis. Something else is seen. I'm not going to touch that topic right now. This is typically, you look at the turbulence seen over here. I can zoom it for you. Now can see very clearly. Look at the turbulence at the level of valve. So this is pulmonic stenosis. It's essentially a congenital disorder. Carcinoid and obstructive vegetation on tumor is another issue. Assessment by transferential echo is very well useful. But number of times we find this pulmonic stenosis with other associated congenital abnormalities like VSD with PS, isolated PS, tetralogy of Fallot. So many places we find this pulmonic stenosis. So what we look at is valve anatomy, valve hemodynamics, hemodynamic consequences and symptoms. In valve anatomy, they are thickened, distorted, possibly calcified leaflet, systolic domain and reduced excursion. Another anatomical abnormality would be what? Narrowed RVOT in subpulmonics, or you can find the RV hypertrophy. Hemodynamics, anything more than 4 is considered as abnormal with a maximum instantaneous gradient of 64. This is the only valve where we talk of peak velocity, not the mean velocities. RVH, RVRA enlargement, post-stenotic pulmonary artery dilatation is quite common. They are virtually asymptomatic. This is a picture again from our own lab. This is a pulmonic artery over here. This is dividing to left and this is dividing to right. This is known as peripheral pulmonic artery stenosis and quite commonly seen in newborns. Why? When newborn is born, what exactly happens? These pulmonic arteries, they are not tuned to large amount of blood to flow to the lungs. So they get tuned over a period of time, and in the meantime, they present with this pulmonic artery. As the volume of blood increases, the pulmonic artery starts dilating and this stenosis disappears. But at the same time, I can quote two of my patients where the patient presented with idiopathic pulmonary artery hypertension, PPHN. And in those PPHN, we couldn't find any definite cause for pulmonary artery hypertension. And when we did a CT pulmonary angiogram, they had a distal peripheral pulmonic artery stenosis, which was not seen in echocardiography. And as soon as we did a stenting to both of those vessels, their PA pressure fall. So remember, if you have a patient of primary pulmonary artery hypertension, must exclude pulmonic artery pathology before you label them as PPHN or primary pulmonary artery hypertension. So the gradients at pulmonic valve would be normal, but if you take your sample volume at this particular place of a right pulmonic artery, you may find a gradient of not very high, 2.6 meters per second. How to assess? Always parasternal short axis view at aorta and focus on pulmonic valve. And remember, make me remember when I'm showing you live demonstrations. In that live demonstration, just ask me, I'll show you a view how you can really focus on pulmonic artery. So subpulmonic at the level below the stenosis, supra distal to the stenosis, and primary pulmonary peripheral pulmonary stenosis at the level of stenosis. This is a cut from guidelines. More than 4 is considered as severe aortic stenosis. But in our day-to-day practice, we call them as mild, moderate, severe. When the gradient are more than 25 to 35, 35 to 45, and more than 45, 36, we call them as mild. 46, we call them as moderate. 56, we call them as severe. But most important thing is just remember, anything which is considered as severe is considered as 4 meters per second of a gradient. That's all in pulmonic stenosis. Not a rocket science, but you have to identify where this particular phenomena is originating. And before I close this segment, I need to tell you one important thing is, if the stenosis level is subpulmonic, as I showed you the first slide, look, this needs surgery. This needs surgery. Pulmonic valve can be dealt with, but these things, they definitely need resections. So if you tell somebody to have an isolated pulmonic stenosis at subpulmonic level or suprapulmonic level, then we have to really look at what exactly these obstructions are. And if it's a peripheral pulmonic artery stenosis, then wait for the time to come till they become normal. All right, this is what peripheral pulmonic artery stenosis is. They disappear over a period of time, so do not have to spend time. Just keep a follow-up when these kids come. Tell them to come and review after 6 months or 1 year to look whether they have disappeared or not. With this few words, let me stop it over here. Thank you very much. And then we go for a question answer. Anybody can ask, open up his mic. And